Hey everyone, my name is Dr. Chad Kuhns. Thanks for hopping on. I am a sports physical therapist. I've worked with a lot of runners, and this is a really hot topic that pops up, especially when we're really inquiring and looking to what's our best running form for our body. And at some point, you've got to address whether you're a heel striker, midfoot / forefoot striker. And I want to really keep this as evidence and science-based as possible. There's a reason that there are millions of dollars being poured into the research-based industry. Although it's not widely applicable all the time, I think it's a really good place to start, and it does give us some very insightful information. There are a lot of gurus and coaches that are using only and exclusively anecdotal evidence, and not that it's not important to use anecdotal evidence where you're noticing what's helping you with the person right in front of you, whether it is physical therapy or whether you're a coach. You still can't be negligent of what the science and the education and the information is showing you from a research perspective. And so I really want us to kind of stick to that, guys, as closely as possible. This is a controversial topic that's being taught differently all over. Hang on to your hat and at least let me get through my presentation before you make a strong decision, before you get too critiquing. You might have been taught by a coach or someone in the past that you must be forefoot for various reasons. I just want to explain what I've been taught and how I use my information to help out runners all the time get back to running pain-free. Speaking of pain, what are the most common injury sites in runners? Knee is going to be number one, pretty by far and large, foot and ankle, and then the lower leg. Notice this is from the knee down. You don't see hip here. You don't see low back here, right? What are the most common overuse injuries in running? Again, it's going to be from the knee down, which will be important as we continue on this conversation. But patellofemoral pain or really just knee pain. IT band syndrome, that's probably all too familiar for a lot of you, and then the ugly PF word, plantar fasciitis, which no one wants to deal with. All right, so it's really important to get into the biomechanics of running, all right? So first off, it's very important for you to understand when you're running, which is a single leg sport, because you're on one leg around 80% of the time. Just take that in. When you land on that one leg is responsible for 2 to 3 times your body weight, right? So if I'm 200 pounds, that one leg could be responsible for up to 600 pounds at that moment. Think about that. Now, and that's if the entire kinetic chain is attenuating that force. What if that force was only from your knee down, right? Now you got 600 pounds just from your knee and below. You imagine doing that 600-pound squat only using your shin muscles and your calf versus at least having your whole body to work with you. Running does have an incredibly high amount of demands on your joints and the muscles, and so therefore the Cardinal Rule, and I say this to my clients all the time, especially for those who want to do couch to marathon or couch to 5K, guys, be fit to run, don't run to be fit. And in other words, people will just want to get off the couch and they'll just want to start running in order to get fit. You have to hit the prerequisites. You have to be fit to run. It doesn't work the opposite way. If it does, you're in trouble. You're most likely having pain. So let's go through the fundamental differences here. So the amount of joint motion we need to consider, the muscular demands we need to consider, the mode of forward progression, and there's 3 more that we're going to cover today. The ground reaction forces, your stride length and cadence, which a lot of my runners are trying to play and change with, as well as your running economy. So with regards to heel strikers, and joint motion, heel strikers by far and large have more hip, knee, and ankle motion. That's a really good thing when we're considering joint attenuation as well, and just being able to get certain areas, hint, hint, the hip, in the game, okay? Whereas our rear foot, let me go back a couple, where our rear foot won't have any part of the body where you actually get more motion. So the heel strikers are better at getting more motion, just to clarify, in all 3 areas, hip, knee, and ankle. Now, regarding energy absorption, this is a really important chart here for you to take note of. And I'm just going to kind of outline here something. I really want you to take a look at the small piece of the pie, which is actually a big number, which you'll see in here in a second. So when you rear foot, you get your hip activated up to about 14%, which is pretty good. And you can see a nice level almost equivocality here between the ankle and the knee. Those are both around the low 40s. So we're doing a better job at distributing our energy absorption in these three parts of the leg, right? So obviously ankle would be a little bit higher, and we'll explain that a little bit further in detail. When you land on the heel, the knees and the quads, which are a big part of it, are doing a nice job of absorbing. And then we actually still get about a 14% carryover into the hips, which is huge. Glute max is our biggest muscle. Let's get him going, or get her going, however you want to call him or her. All right? Versus our forefoot energy absorption. Look at this. So the ankle, in fact, I'm going to give you guys, I'm going to color this in red because I'm not happy about it. The ankle is up to 70% doing all of our work. The knee's down from low 40s, right, to 25%. And look at our small piece of the pie now. 7%. So we doubled, or nearly doubled, the amount of energy that our hips can absorb when you simply land on the heel. That's profound, especially when you're talking 2 to 3 times your body weight, right? All right, let's keep it going. What about the mode of forward progression? And let's just kind of quickly educate you guys on what a heel rocker is versus a forefoot rocker. I'll move my guy here so you can see. So a forefoot rocker, which is the one on the right here, is basically only yielding movement that stems from the ankle. Whereas a rear foot walker, which is really how you're intended to walk and move, you can see how it starts at the heel, but then you get the shin moving, you get the femur moving, and eventually you'd even get the hips moving. So in terms of ergonomics and efficiency, we're going to be more efficient utilizing the heel foot or the heel rocker as our mode of progression versus the forefoot. All right, what about ground reaction forces? So this is kind of where I think some information is misconstrued, and let me just explain. So when you heel strike, you can see there's a sharp, rapid increase, and then it drops down, and then it's attenuated. That's because the calcaneus is the one initially taking that hit. Well, the calcaneus doesn't do a good job at attenuating force. Why do I want to use that? Because it doesn't do a good job. That's why. Because I want my shin muscles, calf muscles, quad muscles, hamstrings, and hips and core to do the attenuating in a short period of time. Right? So if that quickly goes up into my leg, my body has to react, and that's why it gets all the way up into the hip. My hips actually have a chance to attenuate that force. Whereas when you forefoot strike, it's blunted, right? It's blunted. It stops right at the knee and below. In fact, it takes a little bit longer to attenuate it, and all that force is only being done from the knee down. So it's a little counterintuitive, but we actually want that distinct impact peak here to go through a calcaneus which doesn't absorb well, so that it can quickly go all the way up into the hips and be attenuated and widely dispersed, rather than concise and shortened and only loaded from the knee down. I wonder why we have injuries only from the knee down in our primary sites and injuries. Makes you wonder. So again, the benefit from heel striking is that the calcaneus actually requires more shock attenuation because it's just a bone that doesn't attenuate really well. And you get to use all of these muscles. Again, spread that 2 to 3 times the body weight, just biomechanically speaking. Whereas a forefoot strike, it's going to be limited and mitigated just to your midfoot and your calf. And by the way, when you land on the midfoot, you're landing and utilizing that plantar fascia, those ligaments that aren't really intended to do this amount of work consistently, especially for you long runners that are running 10 to 15 to 20 miles a day. Think about the amount of strikes and the amount of weight and the amount of pressure constantly into the underbelly of your midfoot, and you're asking it to do way more work than it's ever meant to do. So guys, stride length and cadence as well. This too is in our favor if we're a heel striker. A forefoot strike will actually require a higher cadence, and you'll actually have a shorter stride length. What does that equate to? Less economical. All right, less economical as a forefoot striker. In fact, studies have shown up to 5 to 9% more economical based upon your VO2 max, which is kind of important if you heel strike. So you tell me, what's your conclusion? If you're not convinced, you're not so sure I'm right, if you want to see what's right on your body, come on in. Give me a call. Let's take a look. I'll do a running evaluation for you, and we'll see if your body's truly made or not to also follow through the heel strike. I will tell you right now, I've had a lot of success converting, and it is a converting process, people over into the heel strike. It might take 3 months. It might take 6 months. But is it worth it for you if you can continue to run the way you want to relieve the stress for your mental health, for your physical health, as long as you want? Would it be worth that conversion? Or are you going to be dealing with annoying plantar fasciitis, posterior tibialis insufficiency, Achilles tendonitis, you name it, let alone fractures or hairline fractures. So I hope that was helpful. Thank you guys so much for hopping on today. Dr. Kuntz here. Take care.